Good morning. Thank you very much to be there. I am Dr. Caton from France, and I have a talk this morning about lengthening of the lower limbs in the short stature peoples. To speak about short stature people, it is necessary to know normal growth and to evaluate the growth. You have the curve here, and for us, short stature people is defined as a child with standing height 2 standard deviation or more or less. And in France, for male, it is 1 meter and 63 centimeters, and for female, 1 meter and 51 centimeters. When you have to do you do evaluation of a short child, you have two questions. First, is this stature proportionate or disproportionate, disharmonious? And is this short stature predictable? There is also a problem of psychological assessment, because in short stature people there is always a difference between real age and appearance age. So this problem has a social disturbance, and another problem is that in France, for example, in 100 years, the overgrowth of the population was 11 centimeters for male and 8 centimeters for female. Another problem, it is a job with a standard height, like army, police, steward, and so on. There is also the problem with the dysmorphophobic subject and the cosmetic lengthening. And the problem of psychological problem of short stature people is the evolution with immaturity and depression with three attitudes. First attitude is poor school work performance. The second attitude is a mascot attitude. And the third attitude is excessive work performance. When you do a therapy of the short stature people, you have always improvement, and you know probably this study this of Judith Ross about 68 short stature people with a treatment with growth hormone therapy, and after 3 or 2 years of growth hormone therapy, there is improvement of self-esteem. So we do, for us, a surgical treatment after the growth. And the modern technique of progressive lengthening been used since only recently, since the second part of the 20th century, allow us to do this surgical treatment, and mainly the Ilizarov method. The lengthening strategy depends on initial height and of the character proportionate or disproportionate of the stature, of the etiology with sometimes epiphyseal lesion, and also of the psychological assessment. And for us, lengthening strategy is that with fore lengthening, with always corset lengthening, femur with orthofix device, and tibial with Ilizarov device, or two lengthening always with Ilizarov device on the tibia, on the leg. And you see on this first slide the corset lengthening, and on the second slide, lengthening of the two tibia. I don't use lengthening knife for short stature people. I use sometimes for leg length inequality, because 3 reasons. First, mechanical reason. For us, full weight bearing is very difficult with lengthening nail. There is also a risk of fat embolism, and it is also very expensive. You have an example of lengthening by Albizia nail, the first lengthening nail. When you speak about lengthening, it is necessary to speak about the complication. So we have described 20 years ago classification of the complication with 3 categories. Patient of category 1 with no complication or minor complication healed at end of surgical lengthening. The patient of category 2 with complication with additional surgery, not planned, but without sequelae after treatment, and the lengthening program being respected always. And a patient of category 3 with sequelae and not respect of the lengthening program. Since 1984, when the Ilizarov method was introduced in France, we have operated on 60 short stature people, teenager or young adult, always after the end of growth. And during this period, 150 patients asked for a lengthening without surgical solution. If we study the patient with more than 5 years of follow-up, it is 44 patients and 110 leg lengthening. 88 tibial lengthening by Ilizarov method. You see the method. I use always the initial method of Ilizarov with respect of the periosteum and the corticotomy. And you see one example of this Ilizarov method with a lengthening of 12 centimeters and a very good regenerated bone. And for femoral lengthening, I use first Wagner, then Kalotasi method. And I use medial shaft osteotomy. I modify the method of Roberto Aldeguerri. And you see here a lengthening of 8 centimeters of the femur with a very good consolidation. And a crossed lengthening. There is in this series more female than male. And the etiology is mainly constitutional short stature, achondro or hypochondroplasia, and also Turner syndrome. The average preoperative height was 1 meter 42 centimeters, and less for crossed lengthening and more for only tibial lengthening. And the postoperative height was for the global series 1 meter 54 centimeters. And you see for the postoperative height for crossed lengthening and also for tibial lengthening. We have observed approximately 3 centimeters of spontaneous overgrowth in crossed lengthening, probably on the rachis. The average gain for us is 12 centimeters and 18 centimeters for crossed lengthening and 10 centimeters for tibial lengthening. The average lengthening for tibial is 8 centimeters, more than femur, and it is secondary to the very good method of Ilizarov, who permits tibial lengthening more than femoral lengthening. And I have manufactured during this period approximately 10 meters of regenerate bone. The consolidation index is approximately 2 months by centimeter. and less for crossed lengthening and more for tibial lengthening. The lengthening velocity is approximately 0.8 millimeter by day. And you see for crossed lengthening and for tibial lengthening. And some example, lengthening of 12 centimeters for this hypochondroplasia, lengthening of 7 centimeters for this Turner syndrome. And the complication, we have a few complications in this series. And we have, for crossed lengthening, 9% of category 1, mainly category 2, and no sequelae, no complication of category 3. You see a complication in Turner syndrome with a fracture of the regenerate bone before removing of the apparatus of orthofix. For tibial lengthening, we have half of the patient without complication in category 1 and 42% patient in category 2, and no sequelae, no patient in category 3. The social professional results are very good, and 10 years after lengthening, all the patients would do it again and would recommend it if necessary for their children. It is the same for the series of Roberto Aldegheri. There is many other experience. The experience of Villar-Rubias more than 20 years ago with the Wagner apparatus. He have a few complications. I am not sure that these complications are so low. The most important series is the series of Roberto Aldegheri with many achondroplasia subjects. And for Roberto Aldegheri, always 4 lengthening, and the average lengthening was 16 centimeters, and with complication in category 3 also. There is also the experience of Roberto Cataneo with cosmetic lengthening, and the mean lengthening for cosmetic lengthening for Roberto Cataneo and the LECO school is 7 centimeters. The result is also a function of the etiology. It is very easy to do lengthening for short stature people in achondroplasia, but it is more difficult with more complication with Turner syndrome, and you see one complication of Turner syndrome you have seen. The indication for us are subject between 1 meter 10 and 1 meter 51 for women and 1 meter 63 for men. More than this 8, for us, it is cosmetic lengthening. Contraindications are defined in the Softcode Symposium 20 years ago, with the subject with high morbidity, bone dysplasia, metabolic bone disease, joint epiphyseal anomalies, and neurological disorder. I don't do operation with smoking patient, and I do no lengthening after 30 years old. When to do the lengthening, it is necessary to spend the end of the growth, and after reflection delay of 6 months to 1 year, a psychological assessment, vascular assessment, and after a planning like this. Which segment with which technique? Mainly bilateral tibial lengthening like this, or crossed lengthening in disproportionate subject. For the lengthening nail, I don't use lengthening nail, as you've seen, for short stature people. In conclusion, it is necessary to remain moderate in the indication of lengthening in short stature people with no technical exploit. And I think that it is perfectly justified and codified surgery if a precise indication and patient warned of the complication. And this treatment allows to complete a medical treatment or to supply it so impossible or insufficient. I think that for short stature people, there is half of the patient with no complication after the end of the lengthening in our theory. And this acceptable morbidity for short stature people allow us to continue this lengthening treatment. Because it is always a window for this patient to think that it is possible to do surgical lengthening. Before the end of this talk, I want to show Léopold Ollier. Léopold Ollier is a French surgeon. It is the father of the orthopedic surgery, and it is the father of the role of the periosteum. And he described in 19th century a book about the regenerate bone. The first two spoke about regenerate bone. Thank you very much.
So, thank you very much for a very nice overview for the lengthening in the short stature people. So I will open this paper for discussion because other topics are a little bit different. Any question from